All right. Well, we'll go ahead and start, and we'll finish with the last 30 minutes. I guess it's a good thing you want me to stay. I'm not quite sure, but I guess as Manal said, it's rewarding for an educator to be up here all day, and you're still here. So thank you very much for coming. What I'm going to do is go over a couple of cases, and this is interactive, okay? And I'm just going to. It's been a long day. We're at the end of the day, and we schedule these lectures such that the more didactic was in the morning, and now we're all familiar with each other, we're all friends, and so on and so forth. So now we can have more interaction at the end of the session. So you guys ready? All right, so this is a 14-year-old male with nasal stuffiness. Okay, everyone see it? So we have this mass right here that's actually located in the nasal cavity. There's a contrast-enhanced study, and this is with fat suppression. Oh no, I did it again. So the most likely diagnosis, this computer thing is messing me up here. So the most likely diagnosis, the reason why I showed this case is because about 35% of juvenile angiofibromas do not have the typical spread pattern to involve the sphenopalatine foramen and the pterygopalatine fossa. And I remember this case distinctly because the pathologist told me it was juvenile angiofibroma. I said, it can't be a juvenile angiofibroma. And he said, why? Because juvenile angiofibromas involve the sphenopalatine foramen and they go into the pterygopalatine fossa. But he showed me the pathology. Now, I don't know. I don't know what he showed me. He showed me a slide. And he said, this is juvenile angiofibroma. You know, for all I know, he may be showing me like a pig's foot, you know, the foot of a pig or something. I have no idea. But that's what he told me. So we actually did a study on this afterwards, and we went back and looked at all the juvenile angiofibromas. And I think we published it a few years ago, and just realized that about 35% of juvenile angiofibromas are going to be isolated to the nasal cavity. So where these have been described to arise from is this small little vascular plexus here that's located right at the sphenopalatine foramen. So that's what we look for when that's just realize that juvenile angiofibromas can have a less typical appearance. So this was the differential that I showed you: JNA, rhabdomyosarcoma, encephalocele squamous cell carcinoma, and hemangioma. So what I want to do is go over the typical findings so you're aware of it, and at least you've been exposed to the differential diagnosis involving the sinuses, especially in a child. So this is what? This is A. So this is juvenile angiofibroma, JNA, okay? So what would rhabdomyosarcoma look like? I think we've talked about it already. Exact same location, right? Exact same location, but the difference is what? This does not have any what? It does not have any flow voids, exactly right. Now this is an encephalocele. Now, one thing I'll tell you is that anytime that you're looking at the sinonasal area and you see a fluid mass, you want to say it's going to be a polyp, right? You have to look at the cribiform plate. Because one day, if you don't routinely look at the cribiform plate, you will miss an encephalocele. I guarantee you. So this appearance is fluid, looks just like a polyp, but you have to look at that cribiform plate. This is an example of squamous cell carcinoma. D is D here. And these typically occur in older men like myself. Again, no flow voids, aggressive lesions, and again, pretty obvious to see on clinically. And this is an example of the hemangioma, and I showed this case earlier, densely enhancing. So this is the imaging spectrum of sinonasal masses that typically arise in a kid. So one last time: juvenile angiofibroma, rhabdomyosarcoma, encephalocele, squamous cell carcinoma, and hemangioma. Any questions? All right, good. All right. Ah, my guava is here. Thank you. I love the guava juice here. It's good. I'd prefer a beer, but that's okay. That's all right. No. You know us Americans, we're all alcoholics. And okay, here's a 14-year-old male that presents with a right neck mass. So the most likely diagnosis is A, metastatic lymph node, B, second branchial cleft cyst, C, thyroglossal duct cyst, E, lymphatic malformation, or E, epidermoid. B. Let's go by show of hands. How many say A? How many say B? Good. Second branchial cleft cyst. So what I'm going to do is I'll talk a little bit about branchial cleft cyst. So this is the classic second branchial cleft cyst. Now, the branchial cleft cysts were described years ago by a guy named Bailey, and his article was written in the 1930s. And I actually went back and read it. It was very interesting. But he described actually 4 types of second branchial cleft cysts. They described 4 types of them. This type that you see here is the most common type of second branchial cleft cyst. So this is a type 2 second branchial cleft cyst. And the way to interpret this diagram is that this is the skin and the platysma, this is the jugular vein, this is the carotid artery, and this is the viscera. This is the pharynx. Okay? So the second branchial cleft cyst, as you see here, notice how it's lateral to the artery and the vein. Everyone see this here? And this is the type 2 second branchial cleft cyst. Now, there are certain branchial cleft anomalies, and you've seen this before, that we learned as a resident that sometimes you'll see a fistula from the tonsil that extends out laterally. That fistula that's involved in the tonsil that we've called a second branchial cleft cyst is actually a type 3 second branchial cleft cyst. So it took me a long time. I couldn't figure out, why is a cyst called a branchial cleft cyst, and then somehow if there's a fistula going to the tonsil, my attendings would say that was a second branchial cleft anomaly. The reason is because there are different types of second branchial cleft cyst, and this is the most typical one is a type 2. Now, one of these, now let me ask you a question. Are both of these second branchial cleft cysts? Why? What information do you need to know? Yeah, what about the patient? One thing you have to always ask is the patient age. So when we first started doing CTs and MRs, and we had a 50-year-old smoker come in, we would call this, look at that, it's an atypical branchial cleft cyst. But over time we've learned it's not a branchial cleft cyst, that this is metastases. So the key thing here is that in an adult to present with a branchial cleft cyst is extraordinarily rare. So in an adult, if you see something like this is obviously a metastatic lymph node. And the way you make the difference that even though there's a very, very thin wall, and you do have a low attenuation center, this is necrosis. And if you look real closely, you can see thickening of the wall, and you can also see areas here of a little bit of solid necrosis within it. So metastatic lymph node here, branchial cleft cyst. So an adults should not be presenting with the second branchial cleft cyst. Okay. So let's go over the spectrum of disease. Ready? So this is our metastatic lymph node, right? This is the branchial cleft cyst. So what would we expect to see from a thyroglossal duct cyst in this area? Midline, right? Midline. But where in the tongue would it be? Yeah. Well, actually, I'm sorry about that. I messed you up. Sorry about that. This is a thyroglossal duct cyst. Now, how do we know that this is a thyroglossal duct cyst? It moves on swallowing, right? That's the clinical example of it. What's the radiological correlate that tells us, that causes it to move, that we see on our CT scan? Where is it located? It's in the strap. That's the key thing. Is that here, this is the cyst that's anterior to it. And look where it's located. See the strap muscle here? The thyroglossal duct cyst is embedded in the strap muscle. So the way the clinicians make the diagnosis, they have the child come in, the child swallows, and if the mass moves up and down, then that's a thyroglossal duct cyst. Radiologically, the way we make that diagnosis is that we see whether or not the mass is within the strap muscles. Now realize thyroglossal duct cysts can be unilateral, they can be unilocular, they can be multilocular. They can be midline, or they can be a little off midline. They can be anterior to the hyoid bone, or they can be deep to the hyoid bone. But the key thing that increases our confidence is that it's embedded in the strap muscle. What about this? This was the lymphatic malformation. Cystic lesion here that's located laterally. That's a little bit of submandibular gland. And this is the epidermoid, which is anterior and midline. Okay, you can take a picture of that if you want. You can take a picture of me if you want. Usain Bolt. Yeah, right, yeah. All right. You know Usain Bolt? Usain Bolt? No? He's the Jamaican runner that won the Olympics. This is his signature thing. Ah, all right. All right. All ready? Okay, this is a 10-year-old male with difficulty swallowing. All right. The most likely diagnosis is A, epidermoid, B, ranula, C, thyroglossal duct cyst, D, squamous cell carcinoma, or E, lingual thyroid. And this will be good. I hear the whole alphabet. Okay, everybody, we're all friends here, right? And quite frankly, the way that I learn is by my mistakes. So if someone shows me a case and I get it right, I haven't learned anything. If someone shows me something and I miss it, I feel a little embarrassed, but I have new knowledge, right? Good judgment comes from experience, and experience comes from bad judgment, right? So, how many people, let's all vote, how many people say A? Come on, raise your hand high. We're all friends. A. How many people say B? Okay, we've got some B's. How many people say C? Got some C's. Pretty even distribution. How many people say D? How many people say E? Okay, you ready? The answer is? Okay, we're done. Bye-bye. We'll leave you hanging. You have to invite me next time, otherwise I'll show you the answer next year, okay? Answer C. Ooh. Oh yeah, all these people that didn't vote are saying, oh, of course I got it right. No, I saw you. You didn't vote. I saw you people. A bunch of chickens. Okay. So let's talk a little bit about the normal descent of the thyroid gland. So the thyroid gland starts here at a specific level at the base of the tongue. And do we know what the name of that is called? It's the foramen cecum. The foramen cecum, you have a group of papilla back here that separate the oral tongue from the tongue base. And it's a chevron-shaped papilla, and right at the apex of the chevron is the foramen cecum. And this is where the embryonic thyroid gland starts. And then over time, the thyroid gland has this descent where it descends inferiorly in the neck and then eventually ends up in the anterior neck. The couple points that I want to make here is that here it is at the foramen cecum, and I want to point out here this relationship with the hyoid bone. See how it's on top of it and deep to it, then it goes around it, and then it actually is inferior to it, and potentially it could be deep to it. So that's why the relationship with the hyoid bone is not a reliable way to evaluate whether or not the mass is a thyroglossal of thyroglossal origin. So that's the normal descent. So if you have a mass that's located here, this is the thyroglossal duct cyst. And the way that it's resected is that they do a cyst trunk procedure. Now let's go over the differences, because I know the majority of people said lingual thyroid. So let's go over see what these things look like. So epidermoid, right, anterior midline, cystic. Ranula, where's a ranula going to be? Paramidline, right? Remember the frog, right? I don't know what's frog Arabic and frog in Arabic. Lupta? Okay. Shukra. Okay. All right. Now, this is the thyroglossal duct cyst, and look where it's located, right at the foramen cecum. This is squamous cell carcinoma, and this is the lingual thyroid. So how do we differentiate thyroglossal duct cyst from the lingual thyroid? And you know the answer. Think about it. What's that? CT density, and why is the density going to be different?
Because the thyroid has high iodine, so it will be high density, while the other one is cyst, so it will be a cyst.
There you go. See, that's the thing is that a lingual thyroid and the thyroglossal duct cyst arise from the same tissue. They're like cousins. Like we're cousins, right? We arise from the same people, right? Eventually we're all the same. We're distant cousins, but we're cousins, right? So we all have the same origin. A lingual thyroid and a thyroglossal duct cyst have the same origins. The difference is that when we talk about the descent of the tissue of the thyroid gland, if the thyroid gland ends up leaving solid tissue that's functioning but is solid, you will have concentration of iodine, and this is why it's dense. So this is lingual thyroid tissue. If the type of tissue that's left is functioning and secreting fluid and develops a cyst, then that's why it is a thyroglossal duct cyst. So lingual thyroid tissue, by definition, is thyroid tissue that's deposited along the course of the descent of the thyroid tissue. If it's solid, it's lingual thyroid. If it's cystic, then it's what? A thyroglossal duct cyst. Got it? All right. Next. A 4-year-old male with the left cheek mass. Ah. Yep, so the most likely diagnosis is a type of first branchial cyst, second branchial cleft cyst, third, or fourth? First? Very confident and very good. So this is the first branchial cleft cyst. So, great, that was beautiful. So, what he did was that this is another Aunt Minnie. So, if you deal with any type of pediatric patient and you have a cystic lesion that arises in the parotid gland in a child, the most likely diagnosis is going to be a first branchial cleft cyst. All right? So I want to spend a couple of minutes just going over, does anybody know what this is? What's that? The branchial arches, right? This is the branchial, we learned this in embryology. Remember embryology? So I never could figure out what this meant. I had no idea. I'd see this, I must have seen this 100 times. And I'm like, I don't know. I just memorized it for the exam and then I forgot about it. But it took me 45 to 50 years to figure out what this meant. I'm not very smart. It takes me a while. Once I get it, but it takes, I'm sort of like a slow processor. I'm like a very slow computer. I'm not like an iPhone or a Samsung, okay? So it took me a while, but this is what? This is the developing fetus, right? So here's the forebrain that turns in the brain. Then we have the midbrain, and then we have all these developing arches here. Right? Everyone see that? So this is the developing fetus, and it's looking to your right. It's looking over here, right? So now, if you take that developing fetus and you rotate it 90 degrees, so now it's looking at you, right? Does that look right? So this is the forebrain here, right? This is the first arch, that's the second arch. Can everyone see that? So the way this diagram is derived is that if you took this fetus and then you cut it in the coronal plane, and then you lift it, this is how you get this depiction. So these are all the branchial arches here. This is the outside, so this is the outside here, and then this is inside. So when you're looking at the branchial arches, the first branchial arch ends up developing to what? This ends up developing to the external auditory canal. This ends up developing into the middle ear cavity. And what do you think develops when between the external auditory canal and the middle ear cavity? That's the tympanic membrane. Yeah. And the tympanic membrane is here. And then we know that the ossicles arise from a combination of the first branchial arch and the second branchial arch. So all of this is how the ear forms. So when we look at anomalies involving the first branchial arch, there is a branchial cleft cyst. And by far and away, the most common type of first branchial anomaly is going to be a cyst involving the parotid gland. There's actually a type 2. There's actually a type 2 first branchial cleft cyst. It's a little papilla here that arises from the bony cartilaginous junction, and this extends inferiorly into the parotid gland. And the ENT surgeons, the pediatric ENT surgeons can actually see this. But we tend not to see this. But from a radiological standpoint, what we will typically see is something that looks like that. So if you see a cystic lesion involving the parotid gland, then we have to think of a first branchial cleft cyst. All right? Then we talked about the second. We talked about that already. Let me move on here so we can. Actually, you know, well, let me do this right here. So everyone knows about the first, right? We talked about the second. The third branchial cleft is the following. So the third branchial cleft arises from the piriform sinus, and it extends superiorly, and then it works its way inferiorly. Now, this was a pathologically proven third branchial cleft cyst. I didn't believe it. I thought this was a lymphatic malformation. But it turns out on pathology, this was a third branchial cleft cyst. So occasionally, if you see a cystic mass that's located posterior to the carotid space, this could be a lymphatic malformation, and that's what I thought it was. But just look at the embryological course of this third branchial cleft, of the third branchial arch, if you will. This is located posterior to the carotid space, so in this case, this turned out to be a third branchial cleft cyst. The other way the third branchial cleft cysts typically present is that they present with recurrent infections involving the thyroid gland or the anterior neck. So I don't know how much pediatrics that you do or pediatric head and neck, but if you do have a patient that comes in with recurrent infections involving the anterior neck, or if you have a child that for some reason has an infection involving the thyroid gland, you have to look very, very closely to see if there's potentially a small little fistula right here from the apex of the piriform sinus that runs down here into the thyroid gland. Because you can see how any type of saliva or something could extend inferiorly and result in the recurrent infections. And this was the fourth branchial cleft cyst. The fourth branchial cleft cyst extends from a sinus tract typically involving the piriform sinus, and this one extends inferiorly into the mediastinum. So on the left-hand side, these actually follow the recurrent laryngeal nerve. So this is an example of a old fistulogram in which the fistula was injected on the skin, and this tract went all the way up into the piriform sinus. So there's the first branchial cleft cyst. There's the second. There's the third. And there's the fourth. You can take a picture of that if you want. I shouldn't let you take pictures. I'll say you have to go to Manal's website to see it again, yeah. She's taking her time. Did you get a good picture? Okay, what about this one? So have you a 1-year-old child that's born with this thing? So what's the most likely diagnosis? Rhabdomyosarcoma, neuroblastoma, teratoma, or anathic osteosarcoma? Okay. How many say A, B, C, D? Perfect. And this is a teratoma. Perfect. So this, a classic example of a teratoma is what we, remember epidermoids are fluid. A dermoid has to have more than one germ cell layer, so dermoids are characteristically identified by the presence of fat. And then if you see fat plus calcification, then you're looking at a teratoma. And in this particular case, we see fat here involving the tongue. And on the CT scan, we can see calcification. And this was the operation. So in this case, this was the teratoma. And look what happened to the tongue. It was a bifid tongue. Now, one thing to remember is that in children, anytime that you have a midline lesion like this, it's always important to look intracranially, because this was an unusual case, but this patient had a duplicated pituitary gland as well too. So anytime you have midline developmental abnormalities, always remember to look at the brain and try to see if potentially they have some type of duplication or other midline abnormality. So all of these are teratomas. This is an example of a large right-sided teratoma. This is a CT scan. Here's an MR scan. Here's another teratoma. And we can see the calcification here. Huge teratoma. See how big that is? Massive. Look at the neck. Tiny, tiny, tiny. And in this case, another teratoma. Now, the challenge is that one of these is malignant. Which one's malignant? 1, 2, 3, 4, or 5? More. Ready? 5. I hear 4 and 5. Do I hear a 3? How about this? Do I hear a I don't know? The right answer is I don't know, but the correct answer in this case was actually number 5. So this was actually a malignant teratoma. So the challenge is on imaging is that it's really hard for us to identify what's malignant and what's benign. The other name is mature versus immature. We just can't tell the difference. So at least in my reports, I'll just put teratoma, and then I leave it up to pathologists to tell us whether it's benign or malignant. Okay. So rhabdomyosarcoma. By the way, let's review. What space is this in? Ah, excellent. Perfect. What space is here? What's the potential space located here? Oh, you remember. What's the space that's located here? Excellent. So, oh, I'm so happy. I'm so happy. When I was young, other things made me happy. Now this makes me happy. This is an example of neuroblastoma. In this case, we have metastatic neuroblastoma, and we have a large mass here, and the calcifications suggest that this is a neuroblastoma. This was the teratoma, and this was a gnathic osteosarcoma. So this was an osteosarcoma involving the mandible. Okay, we'll stop with this. 4-year-old with progressive hearing loss. Most likely diagnosis is otosclerosis, labyrinthitis ossificans, congenital cholesteatoma, or acquired cholesteatoma. History? Hearing loss. How many people say A? You got it. Congenital. Good for you. See, you've been quiet the whole time, right? So you've been getting all. This is congenital cholesteatoma. So let's talk about the different types. We talked about acquired cholesteatoma already. So point number 1 is that if you're trying to differentiate between congenital and acquired cholesteatomas, both of these, first of all, if it's an adult, it's not going to be congenital cholesteatoma, right? That's number 1. Second point is congenital and acquired cholesteatomas can both occur in children. But let me ask you something now. See how many paid attention. What do you think would be the key factor to look at on a temporal bone scan, and seen here, that would suggest to you whether or not it's congenital or acquired? So intact tympanic membrane we can't see very well, but you're close.
It will be more acquired cholesteatoma.
I think that's reasonable, but take it even one step further. Why is the pars flaccida retracted?
Because it's eustachian tube.
Eustachian tube. And if the eustachian tube's obstructed, what do we expect to see regarding the aeration of the mastoid air cells? Are the mastoid air cells going to be aerated, or are they going to be? Exactly. So in order to make the diagnosis of congenital cholesteatoma, everything that everyone said is correct, because we're all around the same area. Number one, remember, acquired cholesteatomas are due to eustachian tube dysfunction. So therefore, the mastoid air cells are going to be opacified. So in order to make the diagnosis of a congenital cholesteatoma, there can be no evidence of middle ear disease, because a congenital cholesteatoma is essentially an epidermoid that's arising from the middle ear. So that's number one. There has to be good aeration. Number two, you're right. The tympanic membrane in a true congenital cholesteatoma should be intact. And they should be able to see a translucent tympanic membrane and see the classic pearly white mass. And then number three, and this has been described, some people claim that acquired cholesteatomas will be a little bit higher than congenital cholesteatomas, and in general, cholesteatomas should be a little bit more inferior and laterally compared to acquired cholesteatomas. But for me, the main thing is to make sure that there's no evidence of prior middle ear infection. So look at the aeration of the mastoid air cells. So, right now you tell me, this will be our last one. If we look at otosclerosis, what type of slide am I going to show? So we have this, and what window is this? Oval window. So here's the rarefaction of bone. Is this fenestral or retrofenestral? Fenestral. And here, the cochlea, we see the lucency. So is this retrofenestral or fenestral? Perfect. Retrofenestral, perfect. This is labyrinthitis ossificans. So here we have the replacement of the cochlea with this fibro-osseous tissue. And then on the CT scan, what do we see? This is the cochlea, and you see this density right here? That's all replacement of the cochlea by the fibro-osseous tissue. In fact, if you look back here, this was the vestibule, and we can see some replacement. We talked about congenital cholesteatoma. Again, we look for aeration of the mastoid air cell, right? Now, that doesn't mean sometimes kids will have a mastoid air cell and they will still have a congenital cholesteatoma, but radiologically, we really can't tell. But if you see that cholesteatoma, a focal mass with a completely aerated mastoid air cell, then you can say it's cholesteatoma. And this is the acquired cholesteatoma. So in this case, normal on this side, on your side, the patient's left side, and here we see a soft tissue mass. There's erosion of the incus, and notice how all of these mastoid air cells are opacified. So this would be acquired, and this would be congenital. All right. So my timer's gone off. I think it's 30 minutes. Thank you very much. It's been a real honor and a pleasure to be here. Thank you for having me.